Care of Patients with Diabetes and Hypoglycemia, Chapter 37. Diabetes mellitus is a group of diseases where there is a disturbance in the metabolism and the use of the glucose. Diabetes mellitus can result in the body's failure to metabolize sugars and starch. Sugars will accumulate in the blood and urine, and the byproducts of alternative fat metabolism, or ketones, will disturb the acid-base balance of the blood, causing a risk of coma or death. There are 4 sets of factors that influence the development of diabetes mellitus: genetic, metabolic, microbiological, and immunologic. 80% of patients with type 2 diabetes are obese, meaning they have more than 20% above the ideal body weight. And they have a higher incidence of type 2 diabetes in people who lead a sedentary life and eat a high-calorie diet. The factors that are associated with the development of type 1 diabetes: there's a family history or genetic predisposition, previous infectious disease, the race, more common in whites, American Indians, Alaskan Natives, presence of islet cell antibodies in the blood. There are factors associated with type 2 diabetes development: older age, obesity, family history of type 2 diabetes, history of gestational diabetes, impaired glucose metabolism, physical inactivity, and race: African Americans, Hispanic Latino Americans, American Indians, some Asian Americans, and Native Hawaiian Pacific Islanders. The classic symptoms of diabetes mellitus are related to hyperglycemia. Hyperglycemia increases the concentration of intravascular fluid, raising the osmotic pressure and pulling water from the cells and tissues into the blood. This causes cellular dehydration. The kidneys try to rid the extra glucose in the urine. Glucose is a large enough molecule to have osmotic properties, and it pulls water with it when it is eliminated in the urine. Patients attempting tight control of diabetes mellitus follow an intensive therapy of blood glucose testing multiple times a day and insulin injections or an insulin pump. The overall goal of diabetes management is achieved when the fasting blood glucose stays within normal limits. The HbA1c showed that blood glucose has stayed within normal limits from one testing period to the next. The patient's weight is normal. Blood lipids remain within normal limits, and the patient has a sense of health and well-being. Older adults will experience hypoglycemia quickly. Older adults may progress to dangerously low levels of blood glucose before signs and symptoms are obvious. Severe hypoglycemia can precipitate an MI, angina, stroke, or seizures. Metformin is the preferred drug for type 2 diabetes. Metformin should be held before surgery or a procedure that requires contrast media and for 48 hours afterward until renal function is verified. Patients that receive oral hypoglycemic agents should know these medications do not eliminate the need for following a diet and exercise program. 1 unit of insulin can cover 15 grams of carbohydrate for most patients. A bolus dose or a correction dose of short or rapid-acting insulin is used to manage elevations in blood glucose and bring the next blood glucose measurement into range. Incretin mimetics mimic the action of endocrines, which are hormones that are released from the intestine. In type 2 diabetics, incretin mimetics lower postprandial blood glucose level. For all patients requiring surgery with diabetes, IV fluids are begun as soon as the patient is ordered nothing by mouth, and the IV fluids are continued until the patient is eating again after surgery. During surgery, an insulin infusion of regular or short-acting insulin may be used. Blood glucose is monitored closely during surgery and every 2 to 4 hours postoperatively. The urine is checked for ketones when glucose levels are high. Rotation sites seen here for injection of insulin. If a patient is on a sliding scale of insulin, it is based on the finger stick glucose results for nutritional coverage and receives rapid-acting insulin before meals. You should make sure that the food tray is in front of the patient before giving them the insulin to prevent hypoglycemic events. If regular insulin and longer-acting insulin are mixed in one syringe, regular insulin is drawn up first to prevent any contamination of the regular bottle of insulin with the longer-acting variety. An easy way to remember which insulin to draw first is use clear to cloudy. Clear, regular insulin is drawn up first, followed by the cloudy or the longer-acting insulin. Remember that every insulin dose must be verified by another nurse as it is drawn up every time. Using this habit will help you meet the National Patient Safety Goal to increase the safety of administering medications. The insulin pump will need to be discontinued for some diagnostic tests, like an MRI. Most patients can safely be without the pump for an hour, but blood glucose levels should be checked before disconnecting and after reconnecting the insulin pump. This procedure has ethical issues that include 2 to 4 donor pancreases are needed for the required number of islet cells. About half to a third of the recipients will develop antibodies that would prohibit any future whole pancreas transplant attempts. Lifetime immunosuppressive medications are highly nephrotoxic. Individuals with diabetes are susceptible to 2 types of complications, either short-term or long-term. Acute complications or short-term arise when blood glucose suddenly becomes either too high for hyperglycemia or too low for hypoglycemia. When a patient is admitted to the hospital with hyperglycemia, decisions about the proper modes of therapy are based on the presence of both objective and subjective symptoms. Type 1 diabetes is more likely to be complicated by ketoacidosis. Type 2 diabetes may cause a hyperglycemic hyperosmolar state. Acetone, a ketone body, is excreted in the urine that can cause acetonuria or ketonuria. It is also excreted from the lungs, which can be detected in the characteristics of fruity odor to the breath. As the kidneys excrete excess glucose and ketones, they also eliminate large quantities of water and electrolytes. These pathologic changes are responsible for metabolic acidosis, dehydration, and electrolyte imbalances. The goals of treatment are to restore the normal pH of the blood and the body fluids, correct the fluid and electrolyte imbalance, lower the blood glucose level gradually, and provide life support measures. In the absence of insulin, the potassium comes out of the cells, and the patients will present with hyperkalemia. If you suspect the patient is in diabetic ketoacidosis, you need to immediately ensure that there is at least one patent IV and anticipate an order for IV therapy. Patients need to understand their diet management. They need to know when to monitor their blood glucose, understand about foot care, and also wearing a medical alert bracelet. Patients need to understand what to do on a sick day and when to call the physician. Hyperglycemic hyperosmolar state occurs primarily in individuals with type 2 diabetes who experience high blood glucose levels because of illness or added stress. Hyperglycemic hyperosmolar state is different than diabetic ketoacidosis because a small amount of circulating insulin remains available. This results in the absence of ketosis and acidosis. The treatment of HHS focuses on fluid replacement and correction of electrolyte imbalances. Rebound hyperglycemia, or the Somogyi effect, this follows a period of hypoglycemia, which often occurs during sleep. When hypoglycemia occurs, the body secretes glucagon, epinephrine, growth hormone, and cortisol to counter the effects of the low blood sugar. Dawn phenomenon is characterized by elevated blood glucose in the morning. It is caused by the release of growth hormone, glucagon, and epinephrine during the night as part of the body's natural circadian rhythm. These specific hormones act to raise the body's blood sugar. The dawn phenomenon is the reason why most individuals that have diabetes do not tolerate carbohydrates well in the morning. 2 out of 3 individuals that have diabetes will die prematurely from a heart attack or a stroke. Gangrene can often lead to amputation and is common in individuals that have diabetes. 60% of the non-traumatic amputations occur in individuals that have diabetes. Vascular changes typically cause poor circulation in feet and the lower extremities. Diabetic neuropathy occurs directly from changes in the renal blood circulation. Visual impairment and blindness are common of diabetes mellitus. Retinal damage will cause visual impairment and blindness, and it can occur in most individuals with diabetes within 20 years of the diagnosis. 60 to 70% of people with diabetes also have mild to severe neuropathy. Pathologic changes in the nervous system cause symptoms, paresthesia, numbness, and loss of function. Diabetic neuropathy affects peripheral nerves causing sexual impotence in men, constipation, neurogenic bladder, and pain or anesthesia, which is a lack of feeling in the lower extremities. Symptoms for non-diabetic hypoglycemia can occur suddenly within 4 hours after a meal is eaten. Carbohydrates that are eaten should be complex, like those found in whole fruits, vegetables, and whole grains. Untreated fasting hypoglycemia can lead to severe neuroglycopenia, which is a shortage of glucose in the brain, and possibly death.